Gotta get like a real camera system in here. We're gonna use this to leverage that. All right. So today we're gonna start respiration. I like breathing, not just in general, but like as a topic. It's a good thing. So first we need to talk about like what's going on here. So respiration, the idea of respiration is getting oxygen in and carbon dioxide out. And I'll tell you this in advance, you already know how all of this works. You're doing it right now. You've known this forever. Air goes in, air goes out. Oxygen in, carbon dioxide out. That's all that's going on here. Oxygen in, carbon dioxide out. All we're doing is explaining the processes that make that happen. So keep that in mind as we go through, like the big picture here of where the oxygen and carbon dioxide are going. Oxygen's coming in, carbon dioxide's going out, and this is just an explanation of why. So 4 processes going on here. Ventilation, which is breathing. External respiration, moving oxygen and carbon dioxide from the lungs and the blood. Moving stuff through the blood as transport, and internal respiration, moving that oxygen and carbon dioxide at the tissues. So we've got to move air in and out of the lungs. We've got to provide a gas exchange surface, which means we've got to get the air really close to the blood. We're not pumping air or oxygen into the blood, and we're not pumping carbon dioxide out. It's diffusing. So we've got to get air really, really close to the blood. And then we're going to transport it all through the system. We're not going to talk a lot about like sound production or the sense of smell, but those are also functions of respiration. The anatomy and physiology of speech is its own topic, and we really just don't have a lot of time to go into that. We've got to prevent all the junk that's in the air from getting into you. And again, get air really close to the blood without drying out your blood. And do that within the confines of the pleural cavity in your chest. So we've got a lot of surface area. If we could spread your lungs out flat, they'd easily cover a tennis court. There's a lot of surface area shoved into the lungs. So let's look at the respiratory system as a whole. We start at the nose, and we end up in the alveoli of the lungs. Most of the respiratory tract is what we call the conducting portion. The conducting portion from the nasal cavity all the way down to the alveoli, it's just a tube. There's not a whole lot going on here. Air's moving. The business part of this is the respiratory part, which is the actual gas exchange that's happening at the lungs and the alveoli. Often you'll hear this referred to as the upper and lower respiratory tract. Upper respiratory tract, right, from like the larynx up, and then lower respiratory tract from the thoracic cavity.
Is that basically the lab?
More or less. Here we're looking at the side. And the lungs, like the heart, are surrounded by a double-walled membrane. Here it's called the pleural sac, or pleura. Just like the heart. Now, one difference here is what this pleural sac is sort of connected to. Now, like the heart, the inner part of that pleural sac is right on the surface of the lung. Just like the pericardium was right on the surface of the heart. But this double-walled membrane, the outer layer of this, and you'll see this in just a minute. So the one that's right on the lung, that's the visceral pleura, and this is true for anything like this. Like visceral always means it's on the organ. So the visceral pleura is like right on the lung. The other side of that double-walled membrane is connected to the chest wall. It's the parietal pleura, and and you'll see this in a picture in just a second. They're still separated by fluid in the middle, but that contiguous membrane, part of it's connected to the wall of your chest, and the other part's connected to your lung. The result of that is that when you move the chest, it pulls on the lung and stretches that out or pushes that in. And we'll look at that mechanism in just a bit. So, the lining of the respiratory tract, epithelial tissue. Through most of the respiratory tract, at least most of the conducting region, it's pseudostratified epithelium. And if you remember pseudostratified epithelium, like the tall cells are on top of the short cells, a lot of it's ciliated, so there's little cilia moving stuff. It's coated in mucus. There are mucus glands there. Connective tissue underneath. It's called the lamina propria. Through most of the conducting region, we also have cartilage that keeps the airway patent or open. Smooth muscle and elastic fibers as we get further down into the lungs to do like bronchoconstriction and bronchodilation and control the flow of air. So here's this respiratory epithelium, pseudostratified epithelium, and you can see these mucus cells are secreting that mucus onto the surface there, and those cilia are constantly moving it. Cilia in the lower respiratory tract are moving mucus up toward the back of your throat. And in the upper respiratory tract, they're moving mucus down toward the back of your throat. The constant movement of mucus to the back of your throat is there so that every time you swallow, you also swallow that mucus. That mucus is catching all the inhaled crap that's in the air. Stem cells, like any epithelial tissue, because there's a lot of turnover here. So mucus catches the inhaled stuff, cilia move it toward the oropharynx, the back of your throat, and you swallow it. Stem cells replacing the old cells. The conducting part of this starts at the nose, the nostrils, the external nares. The nose is an important part of this. It provides a patent airway, so it's open. And as air goes through the nasal cavity, it sort of spins through there because of the shape of the bones that are inside the nose, the nasal concha, which we'll look at in just a second. And the air is exposed to the walls of the nasal cavity. The mucus that's there from the sinuses as well adds moisture to the air. And it's filtered and it's cleaned as it goes through. The nose is also part of speech, right? Part of the resonance of speech, and the olfactory receptors, those nerve endings are there, but we're not terribly worried about that right now. So there's the nasal cavity. These three things are called nasal concha, or turbinates sometimes, because they produce turbulence in the air. So three bony structures there, and air is sort of swirled in there because of that. It's not just a straight shot in. We can see the paranasal sinuses, or at least some of them. There's the frontal sinus here. Behind this would be the maxillary sinus. The ethmoid sinus would sit up here, and the sphenoid sinus back there. These are all paranasal sinuses, hollow cavities in the skull. Nasal hairs filtering large particulate matter that would come in. Mucus glands, again, add that moisture to the air. Breathing through the mouth bypasses all of this. So air that comes through the mouth is not as filtered. It's more prone to catching all this debris, and there's still a system, like this is not like the end of it. There's still a system to catch stuff. It just doesn't get all of those steps. The air is drier, it's cooler, and it's not as optimal as breathing through the nose. In the nasal cavity, the respiratory mucosa, the lining of the nasal cavity, is mostly pseudostratified epithelium. The mucus here is part of your immune system. It's catching stuff. It has, immunoglobulin A in there and these defensins. The nasal cavity is extremely vascular. You're aware of this if you've ever been hit in the face. Your nose bleeds profusely because there's just a lot of capillaries there. Those capillaries are there to add warmth to the air that you're breathing in. So as the air comes in, it's exposed to that warmth that blood brings with it. There are sensory nerve endings here. If any sort of particles get lodged in the nasal cavity, it triggers sneezing, which should dislodge that. Those paranasal sinuses are hollow cavities in the frontal, sphenoid, ethmoid, and maxillary bones. They add warmth to the air and moisture to the air. Now, those sinus cavities, as mucus catches this inhaled debris, if we're looking at something that's like a bacteria, it can cause an infection in the sinus cavity. And the lining of the sinus cavity becomes very inflamed, and the mucus becomes very thick. and then it clogs in that sinus cavity and pressure builds up. And these sinus infections are often rather painful. Over time, if you have just repeated sinus infection, you're pushing on that bone, and that pressure pushes on the bone, and you'll see bone spurs that form in the sinus cavity. And that will have to be, it doesn't have to be, but it will need to be surgically repaired. People that have chronic sinus infection often have to go in, and there are multiple ways that they can go in and sort of repair the sinuses. Either with a balloon, and they go, and I'm not talking about like the freaking TikTok thing, where they shove the balloon up your nose and like inflate it. That's not this. Like they surgically go in and drill a hole and then inflate it like an angioplasty. Or they'll go up like through the roof of your mouth and drill a hole, and allow that sinus to drain. And I've known people that have done this where they seriously drill a hole through the palate into the maxillary sinus and allow that mucus to drain out because it's just so thick and clogged, and they have to go in there and treat the infection. The first time I heard about that, I was like, I'll just die. Hard pass. Like you had me at like drilling the hole in my mouth, but then like the mucus thing, nope, done. Hard pass. All right, so here's the pharynx. The pharynx is from the back of those nasal concha just down to the entrance of the larynx and the esophagus. We divide the pharynx into three parts. The nasopharynx goes from the back of the nasal concha to the uvula here. So the uvula is the hanging down thing in the back of your throat. The oropharynx goes from the bottom of the uvula to where the epiglottis would close here. And then the laryngopharynx is the last part of that before you enter the actual trachea. This is a shared cavity for both digestion and respiration. Okay, hold on to that. So the nasopharynx, posterior nasal cavity, pseudostratified columnar epithelium still. That uvula, the soft palate and the uvula here, close when you eat food. So that when you swallow, it pushes this back like that, so that food doesn't go up and out your nose. If you've ever seen anybody with a feeding tube, that feeding tube goes in through their nose. It's a nasogastric tube. And it's going through their mouth, like it goes in through their nose and then down back through the esophagus, not the trachea. But because that's a shared cavity. So there's that uvula there. We see the pharyngeal tonsils. Those are the ones that are back up here. The pharyngeotympanic tube, we see the entrance of the pharyngeotympanic tube right here. It's just that little indentation looking thing right there. That's the tube from the ear that drains into the nasopharynx there. The oropharynx is what you see, like when you look in the back of somebody's throat, that's what you see. If they've got tonsils, you can see those palatine tonsils. Here, the epithelium becomes stratified epithelium because this is your mouth, right? And there's friction and food and stuff going here. So we've got layers and layers of cells to protect you from that. Lingual tonsils are on the posterior surface of the tongue, but those palatine tonsils are ones that you can see when you look in the back of the throat. The laryngopharynx, last of this, so food and air goes here. It's continuous with the larynx and the esophagus. The larynx starts at the hyoid bone and opens into the laryngopharynx at the top, and then it's where the trachea starts, where the windpipe starts here. That hyoid bone in your throat, and there we go. So here, right, that's that hyoid bone, and it's way up there. Its job is to provide a patent airway. It's not a tube that flattens out. Like other tubes that we'll talk about, I lost the one. You know when that happens. Other tubes that we'll talk about, like the esophagus, the food tube, it's flat. And food just kind of opens it and goes through it. It's never open. This one is always open. Like when you look at it, if we had something to dissect and we cut its head off, like it is an open tube because it's surrounded by cartilage. And those cartilage rings provide this patent airway here. Also here in the larynx, we find the vocal cords. And we find a structure called the epiglottis. The job of the epiglottis is to route air and food the right direction. So most of this is hyaline cartilage, which is the hard, slick cartilage, except for the epiglottis. The biggest cartilage that we see is this big thyroid cartilage. It's like a big shield there. Underneath that is a ring called the cricoid cartilage. And then there are some paired cartilages on the back that are associated with the vocal cords. The epiglottis is elastic cartilage, and it's what closes when you swallow food, so that food doesn't go down the air tube. So here's the front, and we see the hyoid. There's the thyroid cartilage, cricoid cartilage, and then here's the trachea proper. Here's the back, so those individual tracheal cartilages. There's the vocal fold there. These little bitty cartilages here, these are called arytenoid cartilages, and they're attached to those vocal cords. And then here's the epiglottis. And when you swallow that, epiglottis is going to get pushed down over the trachea here, so that food gets routed behind it into the esophagus. The larynx is where we find the vocal cords. And here we see those arytenoid cartilages, epiglottis, again from the back. The vocal cords here create this weird structure that sort of folds over the glottis. When we say glottis, the glottis is the actual opening. So like when we look at this model and we're looking down, the actual hole here, that's the glottis. Epiglottis means above the glottis, so it closes down over that hole. The vocal cords work by slightly closing over the glottis. And what happens is when you push air up and out, they vibrate. So here's the vocal cords. So here they're closed, and air gets pushed up in between them depending on how open that is to produce different sounds. And then that sound is shaped by the mouth, and there's resonance in the nose, and there's the tongue involved. There's a lot of stuff involved in speech. And like I said, like the anatomy of speech is its own special thing. But here's the basics here for the vocal cords. So speech is intermittent release of air. The pitch of your voice is determined by the length and the tension of the vocal cords. This changes, right? You get the pitch of your voice changes as you get older. Like puberty, your voice drops because the vocal cords are changing their shape. How loud you speak depends on how hard you force that air out. This is amplified by all the nasal stuff and the sinuses, and shaped by things that are going on in the mouth. The thing is the glottis has to be open for you to speak. You have to be able to force air up and out to speak. But it needs to be closed for you to swallow. Choking happens when food lodges in the glottis, when food gets stuck there, or here behind the epiglottis, blocking the airway. This is why you don't talk with your mouth full. Also, it's rude. And it's not just rude, it's dangerous. And nobody's gonna feel bad for you when you choke. When people are choking, Heimlich maneuver, and what you're doing is you're putting positive pressure back up on the airway. You're forcing air up and out the trachea and hopefully dislodging whatever's right there and pushing it out. It's very effective. If it doesn't work, put more pressure and try again. Like most of the time, if they're choking on food, then Heimlich maneuver is very effective, and pushing stuff up and out there. Now there are alternatives to that, because in terms of the airway, this is a patent airway here, we've got to get air through here. And so if you've ever seen pick a movie where they do a tracheotomy and they stick that tube in their throat, that's what you're doing, is you're bypassing all of this because something has blocked this upper airway, depending on where it is. Maybe an injury to the throat here has crushed that, and you bypass that. And you let them breathe through that tiny little tube. Or there's something that's blocked the airway up there. I'm thinking like movies where this exists. The only one that comes to mind is The Heat. And if you've ever seen that, like Sandra Bullock attempts that tracheotomy on someone who doesn't actually need it, there's blood everywhere, it's coming up and out, it's terrible. If you haven't seen that, totally watch that movie. For class. All right, so we'll look at that a little more when we get to digestion, but there's the whole idea with the epiglottis, and you can actually see that like where the soft palate's closed right there over the nose as well, so that food doesn't go up and out your nose. All right, so trachea, tube that goes down. It's a giant tube, right? That's all we got. On the back of the trachea, there's a muscle called the trachealis muscle that contracts during coughing to help break mucus loose. And then it branches off into two bronchi. So there's trachea. Behind that muscle tube's the esophagus that we don't care about right now. Here's the lining of the trachea. Now we branch off in the bronchi. The trachea branches off into a left and right bronchi. Those are called primary bronchi. There's two primary bronchi, one on the left, one on the right. Each primary bronchi then enters the lung and branches off to each lobe. That means that the right lung has 3 lobes and gets 3 secondary bronchi. The left lung only has 2 lobes and gets 2 secondary bronchi. The left lung is smaller than the right lung because the heart takes up that real estate on the left side. So 3 on the right, 2 on the left for secondary bronchi. That branches off into tertiary bronchi, and then those branch off a lot more, like 20-something times. By the time we get to the end, we get the terminal bronchioles at like 0.5 millimeter. There's a lot of changes that happen as we go through here too. And you can see this in this picture. So as we go through, like in the trachea, we've got these really like distinct rings of cartilage there. And as we get through, they get more sketchy. And they're not complete rings. And by the time we get down to the smaller bronchioles, they're not rings at all. They're just little plates of cartilage. And in the terminal bronchioles, there's no more cartilage left at all. Not only that, as the cartilage starts to disappear, the epithelial tissue goes from being pseudostratified columnar epithelium with cilia and mucus and goblet cells to just cuboidal epithelium. Why? Because you don't need it. Right? The mucus caught all that crap. By this point, we're good. And also, those tubes are so tiny, there's no room for them to have mucus in them. The mucus would block the tube. So as we get into the smaller tubes, we don't see this, but we do see more smooth muscle. And that smooth muscle is there for constriction and dilation. Now, all right, so all that's the tube. Now we get into like the real like working part of this, and this is where stuff gets a little more complicated. The respiratory zone of this. And the respiratory bronchioles, the alveola. So the alveolar sacs here, they look like this. Okay, so notice that you get these little yellow fibers on the outside. Those are elastic fibers. Those elastic fibers are pulling in. When you inhale, they stretch out, and you exhale, it rebounds back. You can see the smooth muscle wrapped here around those bronchioles. Those are going to be active in bronchoconstriction and bronchodilation. That's what this looks like on the inside. Now, one thing to notice here, and this is an important feature, is what you have is this. They're all interconnected. So then my question for you is, why do you have that and not that? Why do you have this thing where you've got all these little spheres in there and separate little structures that are all combined together instead of like a balloon? What does this give you? surface area. And that's what we need. At each one of these, and we'll see this in just a second, each one of these little alveolar sacs is surrounded by capillaries. We need to get the air and the blood close together in as much as possible. And if you just had this, we'd have capillaries around the outside, and the only place you'd have exchange is around the outside. Instead, we have exchange around each one of those little tiny spheres. If you get this, if we break down all those little sacs in there, that's emphysema. And we don't get enough gas exchange. You can't get enough oxygen in and out of the blood, or oxygen in and carbon dioxide out of the blood, because there's just not enough surface area left in the lungs. And we'll look at that when we get to pathophys later. In order to get oxygen and carbon dioxide across, we have the respiratory membrane. It's about 1/2 micrometer thick. This is the walls of the alveoli, the walls of the capillaries, and their fused membranes. The walls of the alveoli are simple squamous epithelium. Squamous cells are flat, they're thin. We call them type 1 cells. We'll worry about the other cells in just a second. Here's another view of those alveoli, and you can see all those capillaries that are wrapped around them. Surrounded by elastic fibers, always open, like with those little pores to connect them. On the inside of the alveoli, you'll also see macrophages. So these little purple guys, these are macrophages, and they're just, if anything happens to get this far, they exist to clean that mess up. Here's the actual respiratory membrane. There's our type 1 cell, that's the cell of the alveoli, like these little flat cells here. And then here's the capillary, and there's the capillary endothelial cell. So oxygen has to go through here and carbon dioxide the other way. These green cells are called type 2 cells. We'll talk about those type 2 cells in just a minute, so hold on to that. You know where the lungs are, right? They're the things in your chest that are not your heart. Here's a view of the lungs. We can see the pleura here. So there's the parietal pleura that's touching the chest wall, and there's the visceral pleura that's on the organ. That connects the lungs to the wall of the chest. Top of the lungs, the apex, the base of the lungs is bottom. Left lung is smaller. We already talked about this. Awesome. There's the lungs. You've seen lungs, you're aware. Here's the bronchial tree, what it looks like, how many times it branches out. Blood supply to the lungs, pulmonary circulation, we've looked at this. Low pressure, high volume. The pulmonary arteries take low oxygen blood to the lungs. Pulmonary veins bring high oxygen blood back to the heart. There is systemic circulation to the lungs, like the lungs themselves, they have to have their own blood supply to take care of them. The bronchial arteries and bronchial veins. This is not a major sticking point for us, so I'm not terribly worried about this. The pleura, the sac around the lungs, double wall membrane, prevents friction. Okay. So now breathing. Again, this is stuff that you already know how to do. Inhaling, exhaling. When you inhale, air moves in. When you exhale, air moves out. Now, let's talk about the physics. All right, so here's you. On the ground, at sea level. From the top of your head to space, there is a column of air that is pushing down on your head. It's a fluid. The pressure that air is putting on you at sea level is about 760 millimeters of mercury. Pushing on your head right now. We're a little above sea level. Not terribly above, so we're just gonna go with right at sea level for our purposes. Rules. If there's you, and here's someone else that's much closer to space, that column of air is smaller now. As your altitude increases, atmospheric pressure decreases. As you get further up above sea level, there's a smaller column of air pushing on your head. So the atmospheric pressure decreases. When does that become significant? Actually, not for a while. We exist easily at lots of different altitudes. People live in friggin' Denver, which is much, much higher than it is here. People don't live at the top of Mount Everest because it's in friggin' space. And that column of air, there's not enough pressure there. We'll talk about those pressures in just a second. The opposite is also true. As your altitude decreases, atmospheric pressure increases. That's not significant until you go underwater. When you go underwater, we have a different issue altogether. Because now you don't have atmospheric pressure, you have the pressure of the water pushing on you. And instead of a column of air pushing down on your head, the whole ocean is pushing in on you. And the deeper you go, the more pressure there is. Now, that doesn't just affect like you being crushed in a freaking submarine they made at Home Depot. That's not just that. If you're scuba diving, it's also going to affect the way these respiratory gases dissolve in your blood. So this is going to be important in just a bit. All right, so all the respiratory pressures that we talk about are relative to the atmospheric pressure. And for the most part, we just assume that we're at sea level because that'll work. When we say that something has a negative respiratory pressure, we mean that the pressure is less than it is in the atmosphere. Not that it's truly negative. It's not like a vacuum, like we're not in space. It's just less than it is in the atmosphere. We say there's a positive respiratory pressure, meaning that it's greater than it is in the atmosphere. We say there's zero respiratory pressure, it's the same. All right, so now let's talk about some different pressures. The first is called the intrapulmonary pressure. The intrapulmonary pressure is the pressure inside the lungs. It's going to fluctuate as you breathe. It's going to go up and it's going to go down. It's always going to be equal to the atmospheric pressure at some point. When you inhale, when you exhale, the stopping point is when it's equal. It's going to go up and it's going to go down. It's going to fluctuate with breathing. The next pressure that we need to talk about is called the intrapleural pressure. This is the pressure in the pleural cavity. This also fluctuates with breathing, but this one is always negative. Relative to the atmosphere and relative to the inside of the lungs, it's always negative. A negative pressure, when we say negative pressure, it sucks. It's pulling out. So the negative pressure here, this is important. It has to be less than the atmospheric pressure, and it has to be less than the pressure of the lungs, because this is the thing that keeps your lungs inflated. Your lungs would love to collapse. The elastic recoil of the lungs would make them about half the size they are. Not only that, inside the lungs there's fluid, and the surface tension of the fluid would make the lungs about half the size they are. So they would shrink up really small. What's pulling them out is this intrapleural pressure. It's pulling out on them. And we're stretching them out with this. If the intrapleural pressure ever equalizes with the pressure in the lungs, they collapse. And it will bounce back up in the top of the chest, and it's much smaller. The difference between the two things is called the transpulmonary pressure. The transpulmonary pressure fluctuates with breathing, and the greater the difference is, the more inflated the lungs are. So that when you breathe, you'll see this inflation of the lungs, that transpulmonary pressure, the difference increases. And when you exhale, that difference is going to decrease. So, intrapleural pressure, the pressure in the pleura here, intrapulmonary pressure in the lungs, and the transpulmonary pressure, the difference between the two. There's your parietal pleura on the outside and your visceral pleura touching the lungs, and then there's that gap in between the pleural cavity where we find that intrapleural pressure. Atelectasis is the word we use for lung collapse. It's fun to say. Why does atelectasis happen? It's because you get stabbed. Why? I don't know, maybe you deserve it. You'd be surprised how many people get stabbed. Like, lots of people get stabbed. It's a thing. Oh, Lubbock, like, there's a lot of people that get stabbed. It doesn't make the news either, like, they just get stabbed casually. Like, this one dude, like, he came in, lung collapse, atelectasis, he gets stabbed over a board game. I never did ask what game he got stabbed over, but now I'm super, like I regret not asking. It's probably Monopoly.
Ooh.
But like he got stabbed, so the lung collapse. So what happens is when you puncture the pleura, and the pressure equalizes, and the lung collapses. Now, worse than that is if we allow, so the lung collapses, so here's your lung, and let's say it collapses, and now it's like up here. All of this now is just empty space because the lung has rebounded up there. If that wound has punctured the lung itself, air will leave the lung and come out into this space, and it will fill this cavity. It can't go anywhere. You can't exhale that air. It's trapped there. That's called pneumothorax. And in a patient with pneumothorax, every time they inhale, it puts more air into that cavity, and it keeps collapsing the lungs. So every time they inhale, it makes the problem worse. To fix this, you'll have to let the air out of the pleural cavity. You gotta cut a hole in between the ribs and put a tube in there, and that air comes out. It's like popping a balloon, and it makes the same noise. So yeah, the air comes out in a hurry, that fun little squealy sound, and then that takes some of the pressure off that collapsed lung. Then you can reinflate the lung after that. So pneumothorax is air in that pleural cavity, and atelectasis is collapse of the lung. All right, so why does this work? This works because we create volume changes. Volume changes create pressure changes, and gases, fluids, move with pressure gradients. We already talked about this with blood. Blood moves from high to low pressure. Air also moves from high to low pressure. It's also a fluid. This is because of Boyle's law. Physics, Boyle's law. Boyle's law tells us that pressure varies inversely with volume. Physics. Translation from physics. If volume goes up, pressure goes down. Okay, so you've got air, or whatever, in a container. The bigger that container is, the less pressure you've got. If you have the same amount of whatever fluid this is, and you make the container bigger, less pressure. The opposite's also true. You make the container smaller, you put more pressure on it. So now, those gases move with the pressure gradient. When you inhale, what happens to your chest? Is it bigger or smaller? Bigger. Volume goes up. Where does the air go? When you inhale, where does the air go? In or out?
In.
In, that's what they call it, inhale, right? So when you inhale, the air goes in. Why did the air go in? Because your chest got bigger. The volume of your chest increased, pressure goes down, air comes in. Because the pressure is lower on the inside than it is on the outside. And you inhale until they equalize. When the pressure of the inside the lungs equals the atmospheric pressure, you stop. This is an active process. This requires energy. The diaphragm contracts, the diaphragm moves down, the chest gets bigger, pressure inside goes down, air moves in. I always forget this. All right, so accordions. You've seen an accordion. This is a confession. I think I own like 4 of them. I've never played the accordion, ever.
Why do you have all these instruments?
I don't know. But I own like 4 of them. Like people give me stuff. I have kids that are like, "You want an accordion?" I'm like, "Sure." and one of them's like the big freaking piano one. Like I've got like a monkey or whatever to play on this. And then one was like the little bitty one like Cajuns play. It's crazy. Anyway, I always mean to bring one to class as a demo just to annoy people with this freaking accordion. But like when you've got the accordion and you increase the size of it, like when you stretch it out, the air moves into it. And when you push it closed, the air moves out of it. It makes bagpipes would also work, but I don't have that one. Same principle, right? When it inflates, like the air moves in, and when you push it closed, the air moves out. That's what's happening here. When you inflate the lungs, it's happening because the chest is getting bigger and it's stretching them out, and air is moving in. Exhaling is a passive process normally. Like unless you're forcing air out of your lungs, like your forceful expiration is active, but normally expiration is just a passive process. You stop inhaling, what happens? Well, the elasticity of the lungs pulls them closed. Those little elastic fibers When the muscles relax, they close up. Pressure inside the lungs goes down. What happens when you exhale? Your chest gets smaller, pressure goes up, air goes out, until we reach equilibrium again. So here's that, right? The lungs are getting squeezed because thoracic volume is decreasing, air is going up and out. You exhale. So here's our pressures. Here's the pressure in the lungs. When you inhale, it goes down, air moves in. When you exhale, it goes up, air moves out. Here's the intrapleural pressure. Again, that fluctuation, down and up. Inhale, exhale. Notice that intrapleural pressure is always negative. It's keeping the lungs inflated. And then here's the transpulmonary pressure, the difference between the two. And you can see like the biggest difference here is when the lungs are most inflated. Now, inhaling is an active process. It requires energy. And the reason for that is that we're working against three things that are working against air moving: resistance, surface tension, and compliance. Resistance is always the opposition to flow, just like it was in the blood. This is our major source of resistance here, or like opposition here, is this friction that happens with the air. Just like it was with the blood, here's your rules for resistance. Blood, or pure airflow, pressure gradient over the resistance. Gas flow changes inversely to resistance. The more resistance you get, the less gas flow you get, right? It's the opposition to flow. Here's the thing with air, it's insignificant. The freaking airway is gigantic, right? The trachea is a giant tube. It branches off infinity, like all these little branches. So, yeah, there's not a lot of resistance. Resistance is only important when we start to encounter pathology. When we have constriction of the airway. When we talk about bronchoconstriction, like in an allergic reaction, or in asthma, or in chronic bronchitis, or infection, the airway gets smaller and we increase resistance. When you think about increasing resistance, it requires more effort to breathe now. You think about like an asthma. Asthma is when the bronchioles constrict.
Seriously, like we're trying to hear, and all I hear is your side talk. Like it's really bothering me.
Asthma. Strong. Breathe through a straw. Sucks. You get so much resistance on that straw, like a coffee stirrer. A lot more resistance. Normally, nothing. For pathology, bronchitis, asthma, mucus. All these things will increase resistance and make it really hard to breathe. Normally, this is not a thing. We'll talk about this again when we get to pathology, and we'll talk about obstructions to the airway. The next thing we've got, surface tension. We've talked about this in A&P2. Water likes to stick to itself. It's adhesive. If you take like a piece of like tissue paper and you get it wet and fold it over on itself, it sticks. Well, this inner lining of your lungs is thinner than that, and there's still water vapor there. It would like to stick to itself. That's not great for us. The lungs would like to collapse. They would like to stick the sides of those little alveoli together. To prevent this, we have a substance called surfactant. I told you earlier we'd talk again about these type 2 cells. Type 2 cells make surfactants. Surfactant reduces the surface tension of water. It's like a detergent. And it reduces the surface tension of water so that water doesn't want to stick to itself. Again, this is typically irrelevant. The only time it becomes an issue is when you're not making it. And surfactant starts being produced about the last 2 weeks of development. So here in a premature infant, we see infant respiratory distress, or infant respiratory distress. where they're not making surfactant, the lungs don't want to inflate. We can treat this with synthetic surfactant. If you know you're delivering early, like they should with steroids to cause that production of surfactant. This surfactant production is also going to be important in labor. We'll talk about that when we get to reproduction. The last thing that we're working against is compliance. All right, compliance is the change in volume with the change in transpulmonary pressure. In English, compliance is how stretchy the lungs are. You ever seen the clown blow up the stupid clown balloon? Like the long, skinny ones that make the stupid balloon animals out of them? You ever tried to blow up one of those damn balloons? It's freaking hard. Like, you see the clown like stretching it out, like just like if you ever wonder if like clowns are not natural, the fact that they can blow up that balloon tells you there's something wrong. Because it's freaking hard to blow up those balloons and they make it look easy because they're monsters. That's compliance. Some balloons are like super easy to blow up, like just inflate them, but some of them like you could like put a lot of pressure on it and the stupid thing's still not inflating because it's not very compliant. Compliance is how easy it stretches out when you increase the pressure. And normally, your lungs are really compliant. Your lungs are super easy to inflate. Like, if you wonder like how easy is it to inflate somebody's lung, like when you do like mouth-to-mouth resuscitation, like it doesn't take a lot of pressure to push air into their lungs. Awesome. Their lungs are super compliant. Compliance only becomes an issue when it's not there. Scar tissue will decrease compliance. If they're not making enough surfactant, that can decrease compliance. Deformities of the thoracic cage, so like of the spine, of the ribs, these will decrease compliance. If the lungs can't inflate enough, for whatever reason, because they're not stretchy enough or the shape's weird, that's a decrease in compliance. And we'll look at some different diseases when we get to pathology that decrease compliance. And we'll talk about the difference and things. So normally, these factors are fairly negligible, and it's not difficult to breathe. For normal physiology, like we're not using up a lot of energy breathing because there's not a lot working against us here. All right, we'll talk about these imbalances for compliance once we get to pathogens. When we assess a patient's respiratory status, we use different things. Okay, so this is something that we could do, like in lab, we can assess respiratory status. We have sort of the old school version of this, it's called the spirometer. And a spirometer measures displacement of air, moving up and down of this thing. Unfortunately, the way the spirometer works is I give you a tube to breathe into, and you inhale and exhale a lot into it, and then when the lab's over, we pass it on to the next lab, and they also get to breathe into that tube, and that's not cool. I stopped using them years ago when I had a girl in class that had tuberculosis. That was great. I was like, no hard baths now, guys. And then after COVID, like everybody stopped using them just because it's just not, like there's no reason to do this. In a clinical setting, still breathing into a tube, but when you're done, they give you the tube to take, and like you're done, like throw that thing away. You're not going to reuse it. Here, that's not like the spirometers are not set up for that sort of thing here. But this is what we're measuring. All right. So the first thing is tidal volume. Tidal volume is the amount of air that goes in and out with each breath. About 500 milliliters, half a liter. Inspiratory reserve volume. So inspiratory is inhaling. Reserve is what's left. This is how much air you can suck in after you normally inhale. So for males, it's about 3 liters, women about 2 liters. The difference here is in the volume of the chest cavity. Expiratory reserve volume, exhale normally, how much more air can you blow off? And the residual volume is the air that's always left in the lungs. After you blow out as much air as you can, there's still going to be air left in there. That's the residual volume. We also measure respiratory capacities. The inspiratory capacity is the maximum amount of air you can suck in. The Vital capacity is the maximum amount of air you can blow out. So inhale as much as you can and blow off as much as you can. That's the vital capacity. Total lung capacity, how much air can your lungs possibly hold? Just suck in as much air as you can. Functional residual capacity is normally what's going to be left in the lungs. Not after you try to exhale everything, just after normal breaths, what's normally left in the lungs. So all of these things can be measured, and we can use these values to diagnose different types of respiratory illnesses. This will distinguish between restrictive and obstructive pulmonary diseases. We'll talk about this when we get to pathophys. Some of the air that you breathe never ever gets to the lungs. It's in what we call dead space. It's in the conducting zone, from the nose down, anatomical dead space. With pathology, we get some alveolar dead space, but we're not worried about that right now. So spirometer, right, this is how we would diagnose this. We won't. I've been looking at like digital versions of this and just trying to figure out a safer way we could do this lab without giving everyone COVID. We're not there yet. All right, other pulmonary function things. Minute ventilation, the total amount of gas flow in or out of the respiratory tract. Forced vital capacity, how much air you can blow off after you take a really deep breath. And then the forced expiratory volume, and that's just a forced vital capacity like in a time interval. And we'll talk about what these numbers mean later when we get to pathophys, so I'm not worried about this today. The alveolar ventilation rate, right? We take how much air is moving in and out times the number of breaths per minute. You get how much air is moving in and out per minute. Here's the thing with breathing. At normal rate and depth of breathing, effective ventilation rate, like how much air is actually participating in gas exchange, about 70% of the air you move in and out is actually participating in gas exchange. Slow it down, breathe deeper, we can up that to about 85% of the air that you're breathing in. Which is not, it's not a tremendous jump. But if you breathe faster and shallower, you'll drop it in a hurry. It goes down much faster. When you breathe faster and not as deep, the effective ventilation rate goes way down a lot faster than it goes up by breathing slower. At rest, it's effective, right? 70% effectiveness there. That's normal. That's what we would expect. Non-respiratory air movements like laughing and crying and sneezing and yawning. Why do people yawn? Why does anything yawn? Yeah, nobody knows. Freaking birds yawn. Other mammals yawn. I don't know if fish yawn. I don't pay attention to fish, but like definitely like birds and mammals do. And what purpose does it serve? No idea. There's lots of theories on that. Some of it's like a social thing. Like your leader yawns and you're like, oh, it's time to go to sleep. But individuals do that too, like without like a pack. So that doesn't make a whole lot of sense. No idea. It is social behavior though. Like if you've got like one dog that yawns, like they'll all yawn. And again, it works in birds too. So that's a weird one. All right, so now back to physics. To understand gas exchange, we have to understand how gases work. The first basic rule of gases is called Dalton's law of partial pressure. Air is not oxygen, right? Air is a blend of gases. Dalton's law of partial pressure tells us that the total pressure, let's say 760 millimeters of mercury, the total pressure exerted by that mixture of gases is the sum of its constituents. So, the partial pressure of each gas is proportional to that percentage of the gas in the mixture. So here's this. So let's say, for our purposes, atmospheric air is about 79% nitrogen. That means that of that 760 millimeters of mercury, 79% of that pressure came from nitrogen. The total partial pressure of nitrogen is about 600 millimeters of mercury. Oxygen is about 21% of the air. We're gonna ignore carbon dioxide and water, because we just don't care right now. 160 millimeters of mercury. So that's 760 millimeters of mercury that's pushing in on you. 160 came from oxygen. Okay. The next law that we need to understand is called Henry's law. Henry's law tells us that when a mixture of gases is in contact with a liquid, the gases will dissolve in that liquid in proportion to their pressure. And at equilibrium, the partial pressure in the gas on the outside and what's dissolved in the liquid equal each other. How much of that gas dissolves in the liquid also depends on its solubility. Some gases are more soluble than others. Some gases we have to add more pressure to get them to dissolve in liquid. Carbon dioxide is very, very soluble. It is extremely easy to get carbon dioxide to dissolve in water. It's so easy to get carbon dioxide to dissolve in water, we do it for fun in beverages. Like all your fizzy carbonated beverages, we put carbon dioxide and water next to each other, we put pressure on it, and that carbon dioxide dissolves in the water. You'll notice that you don't have like oxygenated beverages or nitrogenated beverages. You can't get nitrogen to dissolve in water unless you put it under a lot of pressure. And that plastic bottle wouldn't hold that much pressure. Okay, so partial pressures, solubilities. Gases move with a pressure gradient. Keep this in mind. You already know where the oxygen and carbon dioxide are going to go here. You already know the end of the story. This is just why this is happening. Okay, you're breathing. Inside your lungs, there's more carbon dioxide and there's more water vapor than there is in the atmosphere. So here's our composition. We don't care about nitrogen. Nitrogen doesn't dissolve at normal pressures. Nitrogen doesn't really dissolve in the blood. Even though there's 600 millimeters of mercury of nitrogen shoving into you, there's not much of it that ever goes in your blood. So not worried about nitrogen at all. We're worried about oxygen and carbon dioxide for the most part. You already know where the things go. So here is the partial pressure of oxygen at sea level. Here's the partial pressure of oxygen in the lungs. Where does the oxygen go? Where do you want it to go? In. You want oxygen to come in, you want carbon dioxide to go out. It's always moving from high to low pressure. Notice here, the opposite. There's a partial pressure of carbon dioxide in the lungs. There it is in the atmosphere. Wants to go out. Oxygen wants to come in, carbon dioxide wants to go out. External respiration is influenced by these solubilities of gases. So, let's look at this. Oxygen. The first thing is oxygen. There's a very steep gradient for oxygen. The partial pressure of oxygen in that venous blood, so the blood that's coming back, low oxygen blood, right, blue, it's coming through those pulmonary arteries, it's going to the lungs. The partial pressure of oxygen in the blood is about 40 millimeters of mercury. In the lungs, it's about 104. That means there's 64 millimeters of mercury shoving oxygen into your blood. At sea level. As we go up, atmospheric pressure drops. That means that as you go up, that pressure gradient drops. There's not as much pressure shoving oxygen into your blood. So you don't get as much oxygen in your blood. As you go to higher altitudes, there's not enough pressure in the atmosphere to shove oxygen into your blood. You've flown on an airplane, like a commercial airliner. It's a pressurized cabin. Like you hear the vents come on before you get off the ground. They're putting pressure in on you so that when you get to altitude, you can still breathe. They give you the whole spiel, like they're like, In the event of a loss of cabin pressure, secure your mask before the child next to you. That mask has pressurized air in it so that you can still breathe. If you have a loss of cabin pressure at altitude, you're so high off the ground that there's not enough pressure in the atmosphere to push that oxygen into your lungs or into your blood from the lungs, and you'll pass out because you can't get that oxygen in your blood. So you put the mask on. Fighter pilots, you've seen fighter pilots, like every freaking fighter pilot movie, like they wear masks because they're not pressurized cabins. So that's pressurized air they're breathing so they can still breathe. Take that mask off, they'll pass out. The Top Gun, I don't remember which one he takes the mask off. Don't take the mask off. So for flight training, the Air Force has what are called altitude chambers. And an altitude chamber is the room, I don't think it's this big. And it's like cafeteria benches in there. And you sit in there like this little table, and it's sealed, and they start decreasing the pressure in the room. And they have you perform tasks. When I did it was like a deck of cards. I was like 12 years old too, so this is fun. So they had us have a deck of cards, and they had us like flip it over, and like say what the card was. And then they start decreasing the pressure in the room. And so as the atmospheric pressure decreases, there's not enough pressure to get that oxygen in your blood, and things start getting weird because you don't have as much oxygen going to the brain, and they're like, what's the next card? And you're like, what card? Oh, cards. And you flip it over, like, what card is that? And you're like, what? And they didn't make us pass out because we were 12, but you'd eventually pass out because that atmospheric pressure is going down. This is why like people that are climbing Mount Everest, like they got the full-on scuba tank thing going because there's not enough pressure to push that oxygen into the blood, and you become hypoxic. It only takes about a quarter of a second for that to reach equilibrium. The red blood cells are in there about 3/4 of a second. That's just redundancy for us. That gives us more than enough time to get that oxygen in the blood at the lungs. And here you see that equilibrium in the pulmonary capillary. The partial pressure for carbon dioxide is not nearly as steep. For venous blood, the partial pressure of carbon dioxide is about 45. For the alveoli, it's about 40. It only takes about 5 millimeters of mercury to shove the carbon dioxide out. You don't have to really push on carbon dioxide. You just have to strongly suggest it move somewhere. You just suggest it and it goes out. It's 20 times more soluble than oxygen. Even though oxygen and carbon dioxide move in equal amounts, the pressure gradient is a lot different. Now, like I said before, nitrogen, even though there's a lot of pressure of nitrogen pushing down on you right now, we don't care. That's not enough to get nitrogen to dissolve in your blood. To really increase the partial pressure of nitrogen before it creates an issue. The only way we can do that is to add pressure. How do we do that? Well, assuming that we don't have like a hyperbaric chamber where we can push it in on you, then it's water. We can make nitrogen dissolve in the blood when we go scuba diving. Scuba divers breathe a blend. Most scuba divers breathe a nitrox. It's air basically in that tank. And then you go underwater. As you go deeper underwater, the pressure of the water starts pushing in on you. And at some point, it will push in so hard that the nitrogen dissolves in your blood. Now, we don't care for a while. If you get enough nitrogen dissolved in your blood, then you have what's called nitrogen narcosis. And nitrogen narcosis is basically you being drunk underwater. It's not a good mix. You're freaking like scuba diving and you have no idea what's going on because you're super drunk. Because that nitrogen has displaced oxygen, it's a mess. You're like, what's that beeping? What's air? It's not a good thing. But what's more common than that is what's called decompression sickness. So you go down underwater, that nitrogen gets forced in your blood. As you come back up, if you come straight back up, you take that pressure off nitrogen instantly. And now it's like opening the Dr. Pepper bottle that just came out of the machine. right? You take the pressure off that carbon dioxide instantly, and it fizzes up and out. If you do that in your bloodstream with nitrogen, it bubbles out in your blood. And often it's called the bends. And those little air bubbles, nitrogen bubbles, will wedge in joints, and it's very painful. It can cause extreme pain, tissue death, it can cause death. So when scuba divers come back up, they have what are called decompression stops. And they come back up and they stop and they exhale. And they breathe off that nitrogen, like you opening the Coke bottle really slowly so that carbon dioxide can vent. They breathe off that nitrogen gas, and then they come back a little further and they stop again and they breathe off that nitrogen gas and they come back up further. And there's multiple decompression stops depending on how deep you go. So with that, why don't we just breathe oxygen? Why don't we breathe pure oxygen, like scuba divers? If you'll notice, like even in a hospital setting, when you have a patient on oxygen, even like the percentage of oxygen is not usually like at 100, and if it is, it's not there very long. Like you immediately start bringing that percentage of oxygen down. And that's because at 100%, if you're breathing 100% oxygen, especially when it's under pressure, you get something called oxygen toxicity. And it creates a free radical and it does some serious damage. We'll look at oxygen toxicity when we look at pathology as well. Normally in a hospital setting, like you've got that higher percentage of oxygen on a patient, and we're just trying to force more oxygen in the blood. We're increasing the partial pressure of oxygen in the lungs by increasing what there is in the air they're breathing, so we can force more oxygen into their blood. Once again, you already know where the gases go. So here's the lungs, right? Oxygen and carbon dioxide. Here's our venous blood. So from the lungs to the blood, where do you want the oxygen to go? And right, oxygen, you want it to go into the blood. So the blood that goes into the lungs, the partial pressure of oxygen is about 40. Inside the lungs, the partial pressure of oxygen is about 104. That pushes the oxygen into the blood. So now here's the blood that leaves the lungs at about 100, and it goes out to the tissues. The partial pressure of oxygen in the tissues is less than 40. It's like 100 in the blood. Oxygen goes from the blood to the tissues. You already know this. Oxygen goes from your lungs to your blood to the tissues. Carbon dioxide following the opposite route. And then here you see it in the atmosphere, right? Oxygen coming in, carbon dioxide going out. You already know where it goes. The reason it moves where it moves is because of those partial pressure gradients and the solubilities of those gases. Ventilation perfusion coupling is matching the amount of blood flow with the amount of airflow in the lungs. And these have to be matched for efficiency. All right, this is where we're going to stop for right now. So we're going to take about a 10-minute break. We're going to come back and we're going to look at the respiratory structures that you need for lab. There's not many, but this first lab section is just respiratory stuff. So lungs, upper respiratory tract, like the pharynx and all of this stuff. We'll do that. So take about 10 minutes, and I'll see you back here. We'll go over that stuff and move from there.